Good afternoon. I'm Diane Duncan, and we're here with Muriel Crusoe and Fadi Hamadani to talk about some complications in the lasers and EBD section. So we'll start off with Muriel, who's going to be talking to us today about a really interesting case of pyoderma gangrenosum in a facial area. So go ahead and start.
Thank you very much, Diana. So you heard yesterday about IMCAS alert with injectables, and today it's about laser. And I chose this case, it's facial rejuvenation after pyoderma gangrenosum, because it's rare, and it was not a case, but it was a question. Just a kind reminder about IMCAS alert. Can we put it in large? So, to put it in large, no, large.
Can you make it bigger on her
Bigger,
screen?
yes, on the screen, for me.
To read it?
This
Yes.
one you mean?
No, you put it large.
พี่ทำให้มันใหญ่ยังไงอะคะ
So,
One second.
IMCAS Alert is a peer-to-peer platform from IMCAS Academy. It's free, and you can post a case when you have a difficulty or if you want to know something more. Thank you. So you can submit anonymously. It's a complication or difficult case, and you get replies immediately from clinicians from around the world in the few minutes, few hours. So it's great to test that, and you can ask proactively. And this is a case that I will present. It's how to prevent a complication before you treat. How it works? So first you choose your topic. You select your case belongs. You can submit your case. You post anonymously if you want, and to the community, and you get answered by experts, clinicians. So this case I will present today. It's the discussions that follows the experts' replies. So you know this doctor from Switzerland. She posted a case from a woman. She had in the past a pyoderma gangrenosum on her legs, and you can see she posted it at 23 hours, and you can see Ronald Finner, coordinator of IMCAS Alert. It ends a few hours later, but also from Sweden, Dr. Jacob Wickström, and from USA. So the case is a rejuvenation. So this woman, 67-year-old, she requests for facial rejuvenation, but 8 years ago, she had an extensive bilateral pyoderma gangrenosum on her legs, very difficult with a prolonged healing. Original records, it's available, subtype, trigger, associated systemic disease, and documented pathogen are all unknown. But already tolerated, we know that botulinum toxin was weakly reassuring at the most. So where we want to work versus where the skin has misbehaved. The target, the face, photoaging, but we have an exhale-rich zone with rapid re-epithelialization and facial pyoderma gangrenosum is rare. On the leg, the warning, atrophic post-PG scarring, proven abnormal and difficult healing. So it's the dilemma is the most effective option, is the most dangerous one. So the temptation is to treat the deep static retids with ablative fractional CO2, and the modality is the strongest resurfacing result. But the fear that any controlled wound on pathogen skin could ignite pyoderma gangrenosum, but on the face, we set out to rejuvenate. And this doctor in her clinic, she has Thermage, Fraxel, and fractional CO2 laser. So pyoderma gangrenosum and pathergy, the essentials. So we have 3 to 10 million annual incidents. The median onset is 59-year-old, female predominance. 20 to 30% of pyoderma gangrenosum patients develop new ulcers after trauma. It's a pathogen. And more than 50% have been associated with a systemic disease. So documented triggers, surgery, debridement, biopsy, needle punctures, IV access, injection sites. And the mechanism is a localized, misdirected neutrophilic response to tissue rendered antigenically abnormal by trauma in a host with altered immune reactivity. So diagnostics remains one of exclusion. Energy is a trauma and the patient has no safety yet. So thermal injury counts. We have published case about PG to skin fulguration, electrical and thermal injury. The wound care rule, specialists report the standing rule to avoid laser in PG because of energy delivery and the inherent pathogen risk. Immunosuppression protects. Traumatic procedure well tolerated when patients were on cyclosporine. And the patient is uncovered, so questioned at 8 years, and of all immunosuppression, she has none of this protective cover. So look about the answers. So first, Ronald Finner. So any breach, even a needle prick can trigger pathogy. So we have to be aware about that. Dr. Robin answered saline IPL hematoma, 2PG ulcers, Crohn terrain. So beware anything that bleeds. Dr. Wilström from Sweden runs a wound clinic, never see a facial PG. About absolute risk, very low, versus plastic surgery, and the middle path. So not surgery test, non-ablative test spot if rapport is good. So, but we have to wait several weeks. So conversions, so all four agree on two invariants, never treat body and legs, and treat with ablatives with the greatest cautions. The disagreement is only about the acceptable threshold on facial risk. So is our face really protected? Yes, with a caveat. The robust fact, we have high pilosebaceous adnexal density on the face, drives rapid reepithelialization. Follicular stem cells are on the bulge, supply progeny to the neoepidermis. The narrows of the Pattergy window and explain why facial PG is rare. Honest nuance, experimentally, the bulge itself may be dispensable in the acute phase, first and 3 days. So credit the adnexal reservoir as a whole, not the bulge alone. Pattergy test reassures less than it seems. There's no specific and insensitive. It has lost sensitivity over decades, and it's not a reliable rules out. Geography matters. Positively is very low in Northern Europe versus Silk Road population. Technique matters. A 20 gauge needle provokes far more than a fine 26 gauge. So disinfection lowers positivity. And negativity is not safe. A negative test cannot exclude a pathologic reaction to a real larger procedure. So damage, monopolar radiofrequency, non-ablative fractional laser, can microthermal zone, intact stratum corneum, it's okay. Ablative CO2 fractional, so it's open micro wounds and thermal injury. So the DR modality desired is discussed. A defensible pathway, we have document on stage, so original record, systemic disease, baseline photos, active disease differ. Face only, body and legs are absolute no. Treat the adnexial rich face alone. Lowest trauma first, non-energetic, toxin, radiofrequency, non-ablative. Avoid ablative CO2 laser. Concealed test post, conservative settings, observe 4 to 8 weeks before any full treatment, and safety net, informed consent, early recognition, corticosteroids never debride. Caveat, it's a negative pathogy test, does not guarantee safety, and immunosuppressive cover is not justified for a purely cosmetic indication. So here are what we test. If you want some paper, you can see here what I found it. And I thank you. So, do we treat?
Do you have pictures of the pyodermic gangrenosum patient that was on the alert?
No, only the two photos of the patient. That's it.
Okay. Maybe there was another case of pyodermic gangrenosum, because I know there was an extensive discussion about how when you look at it initially, it looks like an infection, and people will treat with all sorts of antibiotics, and then they'll resort to steroids, and of course, it's not the right answer. So what would clinically make you suspect, other than this patient's history, pyoderma gangrenosum if you were just maybe a practitioner with not good attention to detail and you'd never seen it before? How would you identify it?
No.
It's very difficult to identify it unless you look for scars in the body. It's very rare in the face. I've never seen. I see a lot.
I never see.
By the way, we treat it now with biologics. That's the way, and it goes away. We don't do surgery on it. I was part of the team that used to treat these. I've done maybe 20 cases. Notorious in the leg. I mean, they just don't heal. But biologics now have been a big game changer for us. No surgery, they fail.
So, which biologics are you using? Topical exosomes or?
No, injectables.
Okay.
Biotherapy.
Monoclonal antibodies. I don't remember the list, but I have it. We refer them to Tel HaShomer, which is a big hospital in Israel, and there's a team there of rheumatologists and dermatologists and plastic surgeons, multidisciplinary, and they treat them using biologics. But in this case, to be honest, I've never heard of one in the face. So I would have treated, I wouldn't have done a CO2 or a phenol, but I would have been a bit more aggressive with my fractional RF settings. I can get rid of a lot of those lines, and I would probably do some of the modalities, that we talk about all the time, exosomes or Renuva, which is the SVF.
I like the question, but look at this patient. She had probably actinic keratosis treated on the face because she has small spots. So
And no pyoderma gangrenosum, so we're lucky. Any comments from
the panel.
or from the audience? Anybody want to ask anything?
In my opinion, diagnosis is very important. Pyoderma gangrenosum is a very characteristic clinical findings and severe pains. So only this picture is hard to know the correct diagnosis, right?
Micro.
Coming to you, sir.
Probably with pyoderma gangrenosum, you have some comorbidities with hemopathy or many things. So for the follow-up, if she clearly, with nothing happened after this, probably, but I'm not sure that it's a pyoderma at the beginning. So maybe. So it's difficult to make a diagnostic. But it's a good question too. If it happens,
Do we treat?
So nobody
Well,
has the answer.
aesthetic when you have such disease, but
Yes.
it was 8 years before.
But really, because I work at hospital for wound healings, okay, every day. So we saw a lot of pyoderma. We see currently pyoderma gangrenosum, but never on face, never. But at each time, they have hemopathia. Maybe 1 year after, or we need to have the follow up for few years after because we need some other disease can happen, or particularly hemopathy.
Ronald, do you want to add something?
No, all good.
No? You did it on the post, so thank you very much.
Any other comments, Patrick?
I think we need to think a different way because if we create an unexpected wound after the procedure, there will be a lot of legal problem because we are supposed to know that the disease, we won't expect that won't happen anymore. So if we do the procedure, I think probably the family will be very unhappy. So I'm not so sure if we need to take this risk to do the facial procedure, which probably will be the least likely to have the skin reaction.
So you're taking into account, very smart actually, the social element and the legal element as well.
Okay.
Any other comments? Yes, sir.
In Korea, we have a lot of accidents, like filler injections in necrosis in the face. Recent trend is a PRP with a closed wound healing with a O2 supply, systemic O2 supply is very popular in Korea. O2. No, it's chamber.
Ah, yes. Cool. Very interesting.
Okay, Fadi, I think you're up.
Am I?
Yeah, you're up next.
Okay.
And Muriel,
Oh,
that
yes.
was lovely presentation. I really love your format about the diagnosis and do we treat or not. That was
Brilliant. Really nice. Hello, everybody. Oh. They're saying that I don't have a file for this lecture, but I uploaded this lecture already. This is the different one, sorry. Here it is. Fantastic. Okay. No, I think I clicked on my chair role. But anyway, I still don't have a lecture here. Yeah, go ahead.
So, Fadi, what is your topic?
So
What are
I
you talking
chose, there was a submission on the EBD alert about doing an energy-based device. In this particular case, they mentioned the brand name, which was Morpheus, in a patient that has previous silicone injection. And so I'd like to talk about that particular scenario and in general, what kinds of safety lessons we can learn from these kinds of issues. Since it is the topic was submitted with marketing name, I will disclose that I am involved with InMode. So I'm one of their global trainers, and I'm the head of the global trainers there, and I'm quite experienced with Morpheus. But the title, in the title there was Morpheus, so I'm not the one adding it. So the case was 60-year-old female, type 2 skin, fit and well. She has had a lot of volume in her cheeks over 10 years, but 10 years prior to her presentation, she had silicone injected. And now she wants to undergo Morpheus for fat remodeling and skin tightening. Is it safe to do this? And does anybody have any experience doing energy-based devices over previously injected permanent filler materials? So I'm going to go through the posts and then discuss some of the literature and my experience. Prashant said that he has a patient who has injectable silicone in her cheeks. And then Dr. Hector Ricardo Galvan Garcia replied by not saying anything, but posting this warning from the FDA. So how many of you are familiar with the warning that was recently posted by the FDA about all radiofrequency microneedling devices, not just the specific ones? So two people, okay. So basically the recommendation is that you have to be aware that they've received a lot of serious complications from radiofrequency microneedling devices. They don't name a specific device, it was across the board. Burn, scarring, fat loss, disfigurement, and nerve damage with the use of RF microneedling. And that they're imploring doctors to discuss the benefits as well as the potential side effects and to report the problems. So then Dr. Quibel thanks Dr. Galvan Garcia for posting that link. She says that she doesn't feel that posting the link alone is enough. You need to provide context, and that these are devices that are quite powerful, and in the wrong hands, of course, you may have complications and problems, and she's concerned that third parties and e-commerce will allow these devices to be in the hands of non-clinicians even. And then she mentions specifically that I might be able to add a few comments because of my experience. Then Dr. Jamil Al-Sayed from Qatar. You can see it's quite global, and this is all happening within minutes. It's a fascinating forum. I have done Morpheus as well as EndoLift in such cases. We have good results, resolution of lumps. But as Dr. Diana said, it can trigger activation of infection, so we need to give good coverage of antibiotics. And he specifically mentions clarithromycin or clindamycin, which I happen to agree with. And then Dr. Prashant agrees. And then Dr. Kolachenko from Ukraine posts that he recently did a Morpheus treatment on a patient that had semi-permanent kind of biostimulant-like injections, and that he feels that the Morpheus activated granulomas in the patient. But in reality, when you look at the video I included here, it doesn't look at all like a delayed inflammatory reaction. First of all, you can't diagnose granuloma without a biopsy, and it doesn't look like a foreign body reaction or anything. It actually looks like accumulations of product. I don't think it had anything to do with the energy-based device, to be honest, but I think there was a misconception there. In fact, Dr. Julia O'Shea from Ireland said that please submit a new post under injectables, and she says that she thinks that it's from the previous PLLA or CAHA more so than the EBD treatment, and I agree with her. And then Dr. Cervoni from the United Kingdom, he feels that even if not very likely, he thinks that because the silicone is there, that we're more likely to induce a thermal burn into the tissue, and that he would want to avoid treating. And then Dr. Hans asks a month later if there's any updates on the patient. No updates were reported, and then I finally decided to speak about it. So I've done many treatments using fractional RF, specifically the Morpheus machine, as well as a few others, on patients who have permanent filler material. And I can tell you that it's quite safe as long as you provide good coverage. One of the discussions was that Dr. Cervoni talked about from the UK is that when you do fractional RF, you create microchannels. And then these microchannels over the next few hours to days may be a conduit for bacteria to enter and create all kinds of inflammatory reactions. So I got back and said that you actually can't create channels if you don't stack the pulses. RF is not powerful enough to create channels. The channels are closed within seconds, if not minutes. I'll show you the paper that proves this. If you stack, if you deliver more than one pulse in the same spot, you may open some channels, but generally not. If you stay superficial, so you don't get the needles to go too deep where the silicone is, you may actually prevent reactivation or problems with any inflammatory components. So as an added precaution, I always give them an antibiotic prior to the treatment and then during the treatment. So this is the paper actually by Roy in the US, Geronimus, who used optical coherence topography to actually analyze multiple energy-based devices and to see which one continued to have patent channels. So CO2 and thulium continue to have active channels for several hours, even days. And every other technology, including fractional RF, there's nothing noticed. Even a few seconds later, you can't see anything open. And there's a lot of myths and a lot of reality about complications. And I think there's a campaign now happening, and we see these trends from time to time, where doctors start to attack certain technologies in particular, maybe because they've seen some bad outcomes from them, maybe because they're enticed to do it for other reasons. But I can tell you from years of experience doing fractional RF, what are the common things that I do see, the very uncommon things, and the things I've never seen. So I've definitely seen PIH, especially in my darker skin population. So in Palestine, we have a population that's originally from Nigeria. So I have some experience treating FITS 5 and 6, and they all have PIH. So I condition them and I prepare them for it. Edema is common. There's different versions of it. You can have a delayed inflammatory reaction, which needs steroids, or just the edema post-procedural, which goes away in a few days. And the tram track marks. These are like papules that appear for several days after the treatment, and there's ways to manage them. In all my years, I haven't seen an infection in my practice. I've seen problems from other clinics, but in my practice and in the practice of most of my colleagues, we haven't had a single infection. We haven't had a single HSV reactivation that we're aware of. There are reports of temporary contour irregularities. I've seen one case in my 12-year career, not from me, from a different clinic, that was temporary and got better. And of course, once in a while, you hear about a delayed inflammatory reaction. I've never seen a permanent contour irregularity from fractional RF. I've never seen persistent fibrosis from external fractional RF, maybe from lasers or internal RF. And I've never, not once, seen a nerve injury. So I don't know why the FDA reported this. I wrote to them, and I haven't heard a reply. Determinants of safety, regardless of which energy-based device you're using, are the patient, the tissue, the device, yes, the settings, but it's not the most important thing, and the operator. And you have to think about all of these things together at the same time before identifying a particular cause. I wanted to speak a little bit about the literature of energy-based devices in the context of silicone, but it doesn't exist. There's a lot of literature on energy-based devices in the context of HA, and there's a lot of literature on silicone, but nothing that talks about energy-based devices in silicone. So we have to kind of imagine or predict scientifically what's going on. Most complications arise because you chose the patient poorly. You have a poor understanding of that tissue, or you have a poor understanding of previous treatments. And previous treatments is a big thing now. I think a lot of these surgeons who are getting up, facial plastic surgeons, I'm a plastic surgeon as well, but there's a group of surgeons that's particularly vocal against anything that's non-surgical, except, unless it's microneedling. But now they're attacking microneedling as well, a couple of them. The skin that we are presented with today, it's very rare that you get a virgin skin that hasn't been exposed to something. Everybody's had toxin or fillers or threads or biostimulants. I mean, it's really there, right? And the skin remembers everything. It remembers silicone and filler and biostimulants and threads and EBDs. And I think with EBDs, energy is not the enemy. Always remember this equation, whatever technology you're using. Diane actually is spearheading a fantastic study now where we're looking at energy-based devices and how they modify the extracellular matrix, the matrikine signaling, and the fat cells. But power equals energy multiplied by time. And energy, you can play with it so that it's slower or higher, and it'll have different effects. And we have formulas for this, regardless of what technology you're using. I mean, this is specific for our technology, but these are results. They claim that it creates fat loss. Well, this is a result of a patient I treated just with Morpheus, using the specific parameters that are designed for her type of condition, focusing on the correct depth, and you get very nice remodeling and tightening and reaccumulation of volume where it's supposed to be. But if I wanted to use it to reduce fat along the jowl or in the submentum, I can do that as well. And it's all about this FSN structure and how you can target it. And the reports that you saw in this post about is it permanent fat loss, facial hollowing, the contour changes that people reported, I don't think it's very accurate. We have edema that resolves. You may have something called adipocyte stunning. The fat tends to come back. Temporary coagulation, remodeling rather than complete destruction. So energy-based devices can be safe, even in the context of permanent filler. But you have to know what you're targeting, what energy you're going to use to target it, if you need to target it in the first place. And if they do have permanent materials, then you need to cover them with the appropriate antibiotics. So the future of safety, it's not just experts and protocols. It's going to be ultrasound and mapping and personalized treatment plans, and AI has a role in this as well. So know what lies beneath. This is the message that came out of this post, and I think I liked the fact that Prashant posted this and tried to inquire prior to the treatment. Know what's there, respect the depth, and treat the patient, not the settings. Thank you.
Thank you, Fadi.
Thank you, Fadi, for your excellent presentation. I would like just to answer your concerns about the FDA report. It's all regarding the complications done by non-physicians people, you see. I totally agree that if you follow all these safety parameters, choosing like the patients, having, as you said, we can also treat phototype 5 or 6 without any complication. But they wanted like to report all these complications done by non-physician peoples. And regarding your case treating with RF microneedling on a patients already treated by silicone, I would also be very cautious and careful because it would reactivate all inflammatory reactions as well as biofilms or other inflammatory nodules. Thank you.
Yeah, talking about the fat loss, I believe that will happen, and because I followed my case for 2 years, and of course on purpose to make the fat loss for contouring, but that the alarm warning actually is many in the States, many done by non-specialists or non-physician practitioner. So that's one thing we made to know. But you know, there one issue probably we need to understand is so-called direct to aesthetic practice. They are getting more and more medical graduates go to aesthetic practice directly without any training. So that will happen in the future. Yeah, so the way we are doing facial contour by RF microneedling, because we believe that every single layer we can manipulate to make it thinner and tighter. So that's why, because we do this one just like we do injectables. So we have to analyze all the layers. But when the practitioner didn't understand the facial anatomy, it'll be very risky. So that in my practice, we calculate in a 3D dimensional image analysis, we can decrease the facial volume from 15 milliliter to 30 millimeter after one single treatment session.
I've seen those numbers, yes.
Yeah, right. So this very
with Quantificare, you can actually measure how
Right,
much volume
right,
loss,
right,
if
right.
you want that, of course.
Yeah, we can do that. But for the practitioner who are not understand, just try to push the energy fluence higher to make it more tighter. That will happen.
I agree.
Yeah.
I'm sorry. Silicone oil is illegal in Korea, so I have no experience. But I think RF micro needle devices, there are two kinds: high energy and low energy. For rejuvenation, many Korean doctors use low energy. Yeah. It's very safe. But in US, the photoaging, I heard the parameter setting is very high.
Very high.
At
You're
that
right.
case,
Correct.
be careful.
Yes, yeah. I agree with 100%.
Yeah, is microneedling RF is in Korea is a very old-fashioned technology. We do lots of procedures in Korea for a long time, but we have never seen such a that kind of complications, side effects.
I agree.
So why the FDA warning that kind of thing abruptly? We used so long time, over 10 years. I've never seen that kind of side effect.
I think
this Korean woman had a lot of silicone.
Silicone is illegal now where I'm from too, but about 15 years ago in Israel, it was a very popular treatment, bioalchemist. So there are thousands and thousands of patients who have it in their lips, and I do a lot of surgery to remove silicone from the lips and in the cheeks and so on.
Morpheus maximum depth is 4 millimeters.
For the phase 4, you can go 7 in the body. Morpheus is a high ablative index technology, but
so deep.
The problem with that is, as you said, high ablative index is intended for certain areas to be used by certain doctors. The fact, I think, that the technology became available at that power to people who aren't medically trained, and they were potentially informed that it's just RF microneedling, it's a spa treatment. I think that mentality created a lot of the misconceptions and the problems. Now that's changing amongst many energy-based device companies. They've recognized that there's a lot of power in this technology. In the right hands, like you, I work in my clinic in Palestine. I also work in Romania. We've done thousands of these treatments. We haven't had a single one of these reports. But these reports will happen when the technology is in the wrong hands 100%, just like when surgery is done by the wrong hands as well. Right. You start to get the issues. So.
Okay, thank you.
Be gentle, please.
In the past, we have two famous, two brothers, two twins. They inject themselves silicone. The brother Bogdanov.
Oh yes,
okay?
They're the.
Okay, yeah. And we have some colleagues. They try to destroy silicone by HIFU on radio frequency. Doesn't happen, nothing. The oily silicone stays like that.
Correct.
And don't overstimulate on nothing. So it's rare, more and more rare, because most of now is forbidden to use silicone in Europe since now more than 20 years. So believe that the risk will be down, because we have some patient, because my father was dermatologist too, and more than 40 years ago, it was very common to inject silicone, but it's depending which silicone. We have pure silicone and non-pure silicone, and we have some inflammatory, some induced menacing. But now I have my patient, this patient of my father, they are more than 85 years old.
And they're okay.
So really, we don't do nothing. And I say, can I do something? I say, no, we stop now.
I actually have a question for Diane, because in the States, I've seen some phenomenal results on acne scars injected with pure silicone. Do you have any experience, and do you think that pure silicone behaves differently than some of the older, the ones that we're more familiar with? Or do you think it's also, because people are still doing it in the US?
Yes, I know that there was one guy, Orintich,
Yeah.
for a while, who was the one who did tons of silicone, even though it's clearly illegal and FDA banned. I think he was able from somewhere to get more purified silicone because he didn't really have a lot of complications.
Yeah,
But I'm like
reports-
you. Pitted draining sinuses, and there were people who had silicone injected, free silicone injected into the breast as well as into the face. And, going back to your comment about surgeons saying anything injected into the face might inhibit their ability to do a facelift at some point, should the patient ever want to do it. That's just a very, very odd
Yeah, me
comment.
too, I agree.
think, most people are not ever going to have a facelift,
Correct.
so you can't prevent people from injecting. But I'm a plastic surgeon, and I do a lot of explant surgery, and, the silicone can cause no reaction at all, or it can cause, a minor amount of silicone, say in a saline breast implant, can cause such severe calcification that you cannot take it out
Wow.
without fracturing the calcium and making a hole in the implant because it's so inflamed. So I think it's a patient-by-patient response, and I don't think it has as much to do with the purity of the silicone as
Immune
the
factors and patient
yes,
factors.
the immune factors of each
Great.
patient.
You use needle to make filler, to inject filler, yes
Yeah.
or not?
Yeah, and
But-
cannula.
And cannula.
Yeah.
And you know that you have silicone.
Yeah,
on
it's
your
there.
needle.
Yeah,
Silicone.
yeah, that's right.
So-
It's coated.
Probably if you inject patient every week, every week, since more, you have a lot of silicone.
There's
inside the
micro
skin.
silicone there now. That's a good point. All right.
Thank you for the
you.
interesting case. Thank you. Now?
Sure, I can do it. So, I think now, Diane, it's your talk. I'll take your seat just for your talk,
Okay.
and then I'll give it up again.
Sure, because I'm sure.
don't see you.
I don't see everybody else, and I don't see my slide. So, is there a way to make the slide bigger? Right here?
Yeah. That one. Perfect.
I would love to have you make me be just a little taller, then I wouldn't have to use the little baby step, but thank you. So today I thought I'd talk about pattern marks and see what everybody is doing about pattern marks, because I think this is an ongoing problem, especially in people like you who do a lot of darker skinned patients. And I find that no matter how much you prep them, how much you speak with them, make sure that they haven't tanned recently, et cetera, there are just a lot of people who get PIH and prolonged pattern marks, even those skin types that you wouldn't expect it. So in this particular case, the anonymous doctor said, "Dear seniors, has anybody noticed track marks, facial track marks post fractional CO2 that are persistent?" And noted that some patients don't develop it with the same settings, and this seems to be variable, and had a patient who wanted to know how to deal with it. And so Diane Quabell called this imprinting. I don't know that my patients would call it imprinting, but she treats it with a different laser. I don't know that I would treat CO2 laser pattern marks with another laser, but for her, it works well. And she notes that she does it at a depth of only 10 microns, which I find that PIH might go deeper than 10 microns. But I think that that's something that we could certainly take a look at, and I'd love everybody's opinion. So Dr. Laubach noted that when asked, are there ways that we can prevent these? I think that a lot of people will do pre-treatment if they have a history of PIH. One of the things that I find is really helpful is, you know, in my area, we have a fair amount of Hispanic patients, some that appear to have relatively light skin. They don't give a history of really having previous PIH, but they're the ones who, when they get an injury or a scar, their scar stays dark forever. It takes forever for that mark to fade. And so for me, this is another question that I ask people other than the standard Fitzpatrick responses. Another question that I wanted to know is that a lot of these PIH or pattern mark patients have 3 different contributing factors. One is pigment, one is red or vascular response, and one is what one of the commenters called mini keloids. Obviously, they're not keloids, they're little papules or hypertrophic scars, but I think there are many contributing factors, and for every person who has this, we need to know a little bit more about, is it a macular or papular rash type thing? How much of it is red and how much of it is brown? And so if we're looking at prevention, anybody in the panel want to talk about priming the skin, bleaching the skin, hydroquinone, kojic acid? Patrick, what do you use? I see you're looking around to the audience for answers. And
No, actually, I'm looking for the staff to help me that because about my presentation. You first.
In that case, as you know, it's a small scar. In that case, I use a fractional laser. To be safe, we use non-ablative fractional laser is more safer, but the effect is minimal. So at that case, I use fractional CO2 laser, but the setting is very low because we target is very upper dermis, and the density is relatively high. At that case, I treat that case many times. The effect is very good. Yeah.
I experience a lot of kinds of pattern mark from microneedling and fractional lasers or Elacore microcoring. So in the case of the fractional CO2 lasers, is a coverage percentage is very important in Asian. So it's more dense and more marks. And a microneedling is usually come from technical errors. If you do the very fast stamping, you have to wait, stamp and wait and pull out. Yeah,
that's a good point.
Yeah, technical error is very frequent in microneedling. And microcoring is no way because it fixed diameter of the 500 micrometers of the microcoring. In the case, it's very hard to treat. So in my case, post-laser or post-microcoring care is very important. In Asia, patient visit the clinic is very easy compared to the Western countries. So daily follow-up to the clinic during the inflammatory phase, or 2 or 3 days. We do the exosomes or PRPs, a lot of things to do to prevent marks or PIH in Korea.
Yeah, what I'm doing to help the patient, I have limited experience because some of them from Malaysia to Taiwan. So what I what I did before is fractional CO2 laser, apply steroid directly, like the laser CT drug delivery, because we believe that the tiny papules is not really normal skin, it's a reaction. So if we just put only once steroid, usually it will help. Not really should be at the same location. So they need to solve the unusual fibroblast activity, for example, if that happen. But you know that we have experience in doing injection to help a patient with steroid or some other skin problem. 1 or 2 times of treatment, steroid injection usually won't make the skin too thin. So I believe that one is one thing we can do. And the other one, if that one is very active, a new one, you can, again, laser CT drug delivery, but this time we deliver exosome, so they can smooth that area efficiently.
Before I give you the microphone, I have a question for you because we see a lot of these papules. It's the most common. I oversee the complications for InMode, so I've seen more than 300 around the world over the years. My question to you is, what dosage of steroids? So you're taking the triamcinolone or the methylprednisolone, how are you diluting it before injecting it?
Well, usually because the hole is so tiny, so I personally don't think the concentration matters, because we're not injecting. If we inject a bolus, actually it will be containing a lot of particle inside. But you know, they're very tiny. Usually we are worrying that if there's something cannot be absorbed or just jump into the hole. So we should make sure that will be absorbed or attached at that area. And usually it will be washed out afterward very soon. So don't worry about that.
Please.
So the same, in my perspective, I would recommend to prepare the skin with all brightening formulas and, of course, a full high protection, tinted, is tinted for the visible light. And then doing non-fractional laser, even several sessions, 1 month apart, and also following the patients with post-care with brightening, vitamin C, and full photoprotection.
I have to say, the one who, in our official protocol, there's a doctor a dermatologist from Israel, his name is Guy Shalom. Jonathan, we know him, both of us together. He treated this same presentation on the neck, these papules, 2 months after a treatment with pulse dye laser, using the purpuric settings, and cleared it from 1 session, gone. So that's another option that we recommend. And we do PB serum as well. There was a question on there about the use of PB serum. PB serum, no disclosures, has been phenomenal in resolving them. Any other comments?
Patrick, I have a question for you. You said that sometimes you'll use steroids and sometimes you'll use exosomes.
Yeah.
What makes you decide on one or the other?
Well, for the older one, actually, the triamcinolone will be better. Old scar. If that
Okay.
happens, it will turn white. But for the very red, I think pulse dye laser is one option I used to adopt, and also exosome, because the anti-inflammatory effect and also anti-fibrotic effect both will work to reduce the papules.
But Patrick, just again on the steroids, you're putting it in an insulin syringe?
No,
or you just drop it after doing something, microneedling or?
Oh yes. For example, that for managing the tiny papules, like a scar, you just fractional CO2, not instead of the needle.
But instead of the exosomes, it's steroid.
Yeah, right.
Now I get it.
Drug delivery, laser
Lad,
assisted.
that's what. Yeah, we do that with 5-FU triamcinolone.
Exosome PRP is the early state
Correct.
of the wound. And why you use vial of the steroid? Just potent topical steroid is enough. Really? Yeah.
Oh, you mean topical steroid?
Yeah. Not so old one. Early. Yeah.
It's the cheaper way.
Yeah.
so
Definitely.
we do it. Yeah. But anyway.
It's another debate.
So, and then I have another question for everybody who has treated these. Diane comes back earlier. She recommended a 10 micron ablative laser, and then now she's looking at erbium YAG 20 to 40 microns, full field ablative. So let's touch on the different lasers and the different indications for those, because I would agree with you. Similar reasoning. If it's red and if it's early, then you would use more of a vascular laser. If you have the papules and it's old, maybe flatten the field with an ablative laser. But what are your thoughts, Fadi?
I tend to, I haven't had these. I've had a delayed inflammatory reaction, which I've treated. But in consulting with most clinics around the world, the most successful was using a vascular laser when they're early, gets rid of them.
And which one would you use?
They're using, I don't have a pulse dye, but they're using pulse dye. And if they don't have pulse dye available, we're finding, depending on which country they're in, we're finding a referral center who has a pulse dye to send them to.
Would you ever use like an IPL or a broadband light?
We've recommended this, and some people have tried a narrow band IPL in the green spectrum with results that were comme ci, comme ça, not as powerful as the pulse dye. When they're white, because we get white ones, I mean, I have cases I can show you that are 6-7 months after Morpheus. Under certain light, you can see them, and the patient is bothered. So we recommend there a laser-assisted drug delivery if they have thallium or CO2. If they don't, then we recommend at least microneedling, trying to get something in there. We also have transcutaneous delivery devices. So there's, Alma has one which is based on ultrasound. It's called IMPACT. You can use high frequency ultrasound to get the material through the skin. And
what material are you getting through the skin?
The cocktail, the triamcinolone plus, our protocol calls for a little bit of 5-FU if it's available as well.
Is that not more inflammatory, the 5-FU?
Not that we've seen.
Okay. Is it a microdose or?
Microdose, yeah,
Okay.
yeah. It's not even, I mean, it doesn't even reach 5 milligrams. It's just a microdose the idea is to kind of calm down the fibroblast activity.
Okay.
It can, if you inject it, like in the cases of fibrosis that we get, it can cause inflammation and pigmentation, but it's one of the best to treat fibrosis. But in these cases, it helps when it's a microdose. That's what we've seen. And then lastly, if all of that doesn't work, then if they prefer, they can also inject the PB serum. And if all of that doesn't work, time with tretinoin and silicone gel. And it takes a while, it takes a year, sometimes a year and a half, but they clear up.
So in the US, we don't have PD serum. What's in it?
Collagenase, lyase, and...
It's the British product?
The?
Is it a UK product or?
It's Spanish.
Oh,
Spanish
okay.
product. It comes in high, medium, and low.
Okay.
Fotini is a speaker for them, I think.
Okay.
And you reconstitute the powder, the enzymes, with HA and some saline, and you can inject it very superficially. And when the papules are early, it works phenomenally. They're gone after one session. When they're white and older, it's more challenging.
So you said it's collagenase and what else?
Collagenase, lipase, and lyase.
Okay.
Yeah. There's some reasoning behind why it works. I wouldn't be the one to tell you.
Okay.
The last thing, just to mention, which is really interesting, is there's a huge discussion about whether these constitute scars or not. I had a bit of a discussion with Moshe Lapido and Hans, actually, on this issue, because they always go away in the end. So are they actually scars, or are they transient papule? I don't know.
Inflammatory papules,
yeah,
maybe?
I don't know.
Yeah. So, and here's my last question. Let's say this is a patient on the left who had acne scars and then has some residual pattern marks for months afterwards. I've had one patient who's had this. I didn't do the original microneedling. It was done at a med spa down the street, and they came to me for a second opinion. And of course, the patient was just beside herself because she paid money for that outcome, and which is worse?
It's not good. Yeah. It's worse.
It's not acceptable.
I don't know what to do. I mean,
This, yes, I think it was 5 weeks.
It's early. It'll get.
So it was early, but still, the patient is very unhappy. How do you handle
I've
that?
had a couple of cases like this, also from other practitioners, not using radiofrequency microneedling, using plasma pens.
Oh, those are
Okay,
bad.
so I'll show it to you over here. What I did for her is I did a lot of actually low energy fractional RF using the resurfacing tip. And I injected a bunch of times PRF in my clinic, and non-cross-linked HA. And I'll show you the results, fully recovered. So you have to support the tissue while it's healing. But I don't know if, I'm sure there's many other ideas and creative ways to treat it.
Well, frankly, I didn't want her to come back to my clinic. I told her she should really go back to the person who treated her, which is what we all say, but that the person who treated her didn't really know what they were doing the first time, so. But it is hard to take on other people's problems, so, yeah. All right. I
Yes.
think we have one more person up.
For this kind of situation, I believe that you send it to your best friend. You send your patient to your best friend. Now, I use a fractional pico. Why? For many reasons. It's less dangerous than the thermal laser, because the thermal laser induces millisecond. With pico, you are more mechanical, but you have a little thermic effect. But my favorite is to use, and you can multiply the number of sessions, fractional pico. But fractional, no? Fractional, yeah. And we are very surprising by the result.
Talking about this, I'm about to get my.
On no risk, because the skin type is between 3 and 4. And when 1064 with fractional pico, it's okay. Because if you induce hyperchromy plus that, they kill you. With fractional pico, it's very difficult to induce some more scar.
But it seems that fractional pico is building collagen in atrophic. I've seen some results from atrophic scars that are mind-blowing. It's actually building collagen. You have to use fractional, not the full beam.
No, the full beam, fractional only.
I'm very excited to get my machine and start using it. Any other questions or? So this is different types of pattern marks. How would you do it, Diane?
Oh, I basically really didn't know what to do, but because it was still pretty early, I treated her because she had a really dark skin type for my area. I treated her with some topical TXA, which seems to be better in my hands than the older Kojic or hydroquinone.
Okay.
So I used a combination of TXA. I have a 2910 laser that has the 10 micron setting. So I did that with some topical exosomes just to basically, because that is, they say it's a cold laser. It's not. Nothing about lasers is cold. But I treated her with sequential topical serum, exosome serum, and the exobalm that I make myself.
Amazing.
And after, it was probably 2 months before it started fading. And then she didn't come back to see me, and I didn't call her, I must admit.
All right. Any other comments, questions? Yes, please come up. There's a microphone right there. I will rest my back just for a few minutes.
Thank you so much for very informative inputs. Well, in our country, India, we usually see type 5, type 4, and it's very common to get this sort of patterns. And what I have seen in my 14 years of practice is, if you're really treating scars, there is no way out that you won't deal with this, because you have to ablate the tissue. And at the end of the day, if you're not ablating it, either patient is not going to remain happy, or he is going to have these marks. This is the story. So what we do is we counsel them. In our India, we have east-facing houses because we have rituals. We worship sun there. So it's supposed to be, a sign of goodness if your house is east facing. So mostly getting tan is very common. And so what we focus on is we prime our patients very nicely. We counsel them when we are doing any ablative treatment. There's gonna be downtime of 2 to 3 months. In our pre-priming sessions, we make sure that we are calming down the melanosomes. Also, we put them on very calming regimes like niacinamide, tranexamic acid. All those protocols are very wonderful, like superficial lasers, non-ablative lasers, be it like pulse dye lasers for the erythema and stuff. But we can't afford to have all those lasers because our patients doesn't pay us. So the other part, what we have, bypass this process, and what we have done is we put our patients immediately on topical metronidazole, tranexamic acid to calm down the inflammation. We make sure that we are putting our patients on very mild topical corticosteroids from day 5th or day 6th. When scabs are fallen off, we make sure that patients are applying, we keep shifting our regimes to like as a mild topical retinoids like azelaic acid, then to hydroquinone, and then to stuff. Like, so we manage our patients and PIs like this, and we prefer putting them on milder regimes like chemical peel rather than inducing more heat, because more heat is going to create more activation, and that might become a problem for us. So what we choose over it is Q-switch 1064 nanosecond with like 10 spot size, very low energy, multiple passes we can do. Also, what I am doing since 2-3 years now is MLA toning, which is micro lens array. So we have, in my device, there is a setting when I put micro lens array to my device, so the pulse duration drops to 5 nanoseconds, 4 to 5 nanoseconds. So, and it is in fractional mode with 10 spot size. So I am able to deliver a lot of energy with the bigger spot size. That also gives us like very good
like a fractional Q switch.
Yeah,
Very good. Thank you for those great tips. I really appreciate it. We're going to move on to the next session. So we have, is Dr. Warissa here? Her session is supposed to be at 3:30. So I think we're running ahead of schedule. So we can have more discussion. And it doesn't have to be just about cases. We can ask each other all kinds of questions to gain from each other's immense wisdom. Please, come on up. And then I have a question for the group.
Sorry, also to add, like, we also make sure to take proper history of our patients prior doing these procedures.
Of course.
Because if they have a tendency to pigment, we also see the palms to, there is a palm test, the crease test. If they have darker creases, we try to do a spot test first. And like, if it is a single atrophic scar, we'll do a spot test first, see the response, and then gradually shift to
Awesome.
ablative.
These are all very good tips, very, very important strategies. Thank you for sharing. Okay, let's talk about a couple of themes until our next speaker arrives. How many people are treating acne scars or see patients with acne scars? Okay, may I ask a couple of you to share with us what you're doing? Because this is a hot topic, and more patients are seeing phenomenal befores and afters and are becoming convinced that these kinds of results are achievable. Are you able to get your patients to very high percentages of clarity? What are you doing? Are you doing ablative? Are you doing phenol? Are you doing subcision? What kinds of things are you injecting? Are you using biostimulators or not? Let's do a little bit of acne scar talk, because I think it's very relevant. Until our next speaker.
Okay. Well, in my practice, I usually, I think we should put, well, in my opinion, I think we should put the so-called acne surgery, especially subcision, put at a higher position. Because currently, most of the information always emphasize the demand of the CO2 laser or all kinds of laser, and emphasize you have to treat patient repeatedly. But unfortunately, I don't think that work good enough. That cannot satisfy our patient. So usually, I do subcision first, and no matter what, actually I use, Norcor needle actually is a little bit large and a little bit expensive. So I use 18 gauge needle and work the same way, like a no-core. So if I would like to describe how I use it, just like peel the orange skin. So you have to follow the curve or contour of the scar and then make sure you can do complete detach of the epidermis and the dermis. That can make sure after every single session that the scar size or the scar shape can be much shallower than one. And after that, I do fractional CO2 immediately because I used to try separately because the patients sometimes they don't want to do 2 sessions together until one day the patient say, hey, Dr. Huang, I found that the combination at the same day usually work much better than a single separately. So this is one thing I would like to do. And also my opinion is different from the common because ice pick also work quite well. So if you can do like this, so they can separate the epidermis and completely detach from the dermis. So, but so this is one thing I could do for almost all my patients. But the patient usually have to wait for another 3 to 6 months to make sure the regeneration or tissue remodeling occur completely. Then we can do another time. Usually 2 or 3 times of treatment session, most of the deep scar can be improved and the patient can accept the result. This is one thing I'm doing.
Any other strategies or ways?
I-
Please. Yeah, go ahead.
Yes, perhaps as dermatologist,
Yeah.
when I have recent acne scars with inflammation, I use PDT.
PDT, pulse
Yes,
dye.
photodynamic
Photodynamic,
therapy.
Really?
And you can have good results
Wow.
for acne, but also for acne scars. And it's the second time, so I do 3 sessions, 1 month apart. I wait 6 months, and then, if necessary, I can do a subcision and fractional CO2 laser.
That's phenomenal.
Yes.
I don't have experience with it.
Yes, you
Early scars and red
early
spots,
scars, yes.
but it's yeah.
Yeah, she said early scars, but that's phenomenal. Very nice. You had some comments?
One comment to add to Patrick's practice. We always should also start by explaining to our patients that we will not be able to vanish their acne scars, but to reduce them and to avoid like unrealistic expectations. And I'm totally agree that we need to have synergistic effect by combining energy-based devices, injectables, yeah, so we need to act on these different levels. I'm always starting with subcision, and then I have a RF microneedling, a fractional laser, ablative, non-ablative.
Dr. Lee is a Korean scar master.
Please tell us.
As you know, there are several kinds of scar treatment in Korea. You know, the ice pick, rolling scar, and box scar. Recently in Korea, new technology is developed. It's a laser-induced shockwave therapy. It's like a hammer. So depressed scar, we do the shockwave, very high power, the scar even. And the filler complicates skin nodule. At that case, we use that therapy. It breaks the nodule. It is like a hammer. Yeah, laser-induced hammer.
So it's laser-based shockwave.
Yes, yes, it's very strong. Yeah, later. Yeah, we use this treatment for under eye bag treatment. Yeah.
And
Go ahead, and then there's a question. No, please go ahead. Add your comments.
I will comment one more trend, acne scar trend in Korea. That is a injector. You can see the injector through the laser-induced microjet injector, or is it like electro-pumping injectors. So we use biostimulate, put inside to the scar, like a PLLA, PDLLA, through that kind of injector. So in my case, I make a window with a shallow CO2 peeling or abrasion in the shoulder areas, and then using an injector, I put a PLLA inside of the
edge of the scar you do with the CO2, and in the center you
not strong. It's just a pill. Yeah, peeling. Yeah, that's very popular in Korea too. So yeah.
Please,
Sorry,
question, comment, whatever.
I've got some question about the subcision because sometimes when I do the subcision, it might got refibrosis, so it sticks much harder.
Yeah, that's a good
So
point.
now-
Patrick, it's all yours.
Well, that's why we do fractional CO2 immediately. So because we can do some tightening effect, actually you can destroy the structure. So the thing that doesn't mean that we do subcision can solve all the problem. But if you can separate the very fibrotic dermis and the irregular shaped epidermis, that's one thing we have to do. So that the refibrosis actually is easier. So for example, you can do subcision and then followed by applying something that probably can anti-fibrotic. That's something you can do.
That's what we are trying to do is fractionated CO2 laser firstly, and then subcision, and then inject PLLA. But before the injection, we will vacuum it with some air.
I know.
Balance
Yeah,
and the
yeah.
PLLA so that it will not refibrosis.
Okay, so I'm not so sure if I have done so many patients, but I didn't see so much that after the total refibrosis make the scar come back again, return to the basic appearance. So I do believe that right after the procedure, immediately actually looks 100% smooth. So that's correct. But that doesn't mean that it should keep the same status from the time after your subcision. So you'll see that the improvement probably after one procedure about 30 to 40% improvement. That has been good enough.
Thank you. Thank
Right,
you for the answer.
right.
And another question that I want to know the specific parameters about those deep scars for those ice pick. Because for some doctors, they tend to have very high density, high energy just in the middle.
No.
Some of them just
I don't think it's possible to accurately target at that area. It's not possible at all. So usually I do that. You can just do subcision and do that fractional CO2 laser. And remember the density, the coverage should be very low. And usually, because of the risk of hyperpigmentation, what happen? And don't push the boundary with all your effort, because that they will come back again. So yeah.
do you push the border?
No, I didn't do that. That my teacher, my professor told us before. But after I know that, I find my way to do subcision followed by fractional CO2 laser. Usually I promise my patient probably after 2 or 3 times, usually 3 times of treatment, you can get about 70 to 90% improvement. Wow. The patient usually feel more comfortable. So usually we rarely more than 3 times.
So Patrick, Fadi, anybody here, have you used a 2910 laser coring device?
I have not. I know you have it. It's ultra pulse.
No, it's ultra.
It's very expensive.
It's ultra clear. Yeah, but somebody mentioned the Ellacor.
Yeah, that's not good.
Yeah, it's not good. Yeah, but I have the laser coring 2910. I think it's really, really good. I have somebody with a single treatment who probably got maybe 75% improvement. Wow. And the nice thing is that it's really good for skin laxity, but the best use that I've seen of it is for men who have that really thick, non-pliable skin, especially in the hair-bearing skin area, because I don't have the patience to do subcision and, the time to do that. But this is a mechanism that I found is almost like a combination of subcision followed by your CO2, but it's only in one step. I haven't had any scarring, but you have to go up on the density, so I did 2 millimeters, which is quite deep for this device, and a 4% density, which is really much more than 4%. It took him maybe about 11 days to re-epithelialize. He was not happy, really not happy. And then 2 months later, he was so happy he couldn't not tell everybody. So if you have a chance to give it a try, I'd recommend it.
Am I? Oh,
Please.
Yes.
Yeah, and then we'll go to the doctor because
Sorry.
you actually asked first.
We have so many possibilities, okay? As I use fractional, non-fractional, TCA cross, phenol cross, as you say. I prefer to use a subcision, but with a thermal effect. That means a laser or under RF. That only subcision, but only mechanical. But
So the laser is like the probe.
yes, or under RF.
The
So for subcision.
Yeah,
prefer
I do that as
to
well.
add some
Correct.
thermal effect. But my problem is not to treat the scar. It's the sagging skin, and after 5 years, 10 years, the scar come again. So you need to inform your patient that you can treat now. It will work very well for 1 year, 2 years, 3 years. But after that, when you have the sagging skin, the relaxation,
It will
come
reappear.
again.
Yes.
So you have to inform, you have to have maybe to have some procedure with time to maintain the final result.
I agree.
My favorite is to use any laser you want, but most of the time, in maybe more than 70%, I use HA below, different kind of HA, just to make projection, just to make some hydratation, just to perform. And we do some split CO2 laser alone. After 5 years, if you inject just after with a fanning technique HA, the result, you maintain more than CO2 alone.
Longer, because
Yes,
you did
but
the HA.
longer.
Brilliant. Okay, thank you that's a great tip. Please,
Am I allowed one more question?
you're allowed
It's
as many questions
it's
as you want. We have time.
Comment and a
Please,
question.
go ahead.
I'm from the Philippines, and
Welcome.
we treat a lot of patients with darker skin tone. And the difficulty usually, my question is about syringoma and sebaceous hyperplasia on the nose. I find it particularly difficult to treat, although my experience is treating it the traditional way, the old-fashioned electrocautery, works okay, except that for skin of color, it tends to heal more slowly, and the hyperpigmentation is there, comparing it to like a CO2 laser. But I just want to know your opinion how you would best treat syringoma, and especially the sebaceous hyperplasia on the nose specifically. Thank you.
Patrick, do you want to say anything?
Yeah, okay. I'm the old school. Actually, I compared to fractional CO2 or the laser, ablative or non-ablative. Actually, electricity to burn is the most effective way. But the thing is not to ablate everything, all the layer. You just to do punching. And punching for example, the small one, you do punching for 3 times, just around that main lesion, and leave the skin crust over there. That will significantly decrease the risk of hyperpigmentation. And also, we also have to remember that I kindly ask that your patient saying that probably need 2 or 3 sessions. If we get rid of it completely at 1 session, it will make a hollowness, although it's not a scar, but it will take time to make them coming back. So that's something I will remind our patient that usually patient can accept. And regarding syringoma, it's also the same. The previous one I'm talking about is sebaceous hyperplasia. But for syringoma, this is one that you can advise to your patient. I know some of my friends practicing in Australia. Actually, they do fractional CO2 laser, but I don't think that works because fractional CO2 laser also damages surrounding skin and not really targeting at the syringoma itself. So also compared to the cauterization and the CO2 laser, I think cauterization is a safer and better option because we can penetrate deeper instead of superficial ablation. Yeah, that's my opinion.
As you know, syringoma, there is a many type of syringoma. Small size, at that case, we use phenol method. The phenol method is CO2 ablation deep dummies, just spot. But large syringoma, we puncture several points. And after that, some Asian patients left hyper or hyperpigmentation on the lesion. At that case, fractional CO2 laser, very superficially, it's okay. And in some Korean doctors use insulated micro needle it insert the syringoma and push the power. But the effect is not immediately. CO2 removal is after that, the syringoma go down. But RF insulated micro needle, it takes 2 months, I think. On the nose, there is a small nodule. It's a popular acne scar on nose. It is sebaceous hyperplasia is like a volcano, but it is a popular acne scar. It's common on nose, chin. At that case, is the same. Small size, you remove the lesion, very small diameter, but bigger, you make a puncture. I recommend that case, opium is more suitable because the short laser is there is some thermal effect. After that, the elevated scar get down and recur. So I recommend small size opium yak laser, multipuncture, it's okay. Yeah.
Fantastic. Yeah, and I'll give you two right after.
Okay. You first.
Yes. Thank you. You recognize the boss. Okay. Yes. First thing, for normal skin, I use radiosurgery. It's very efficient. But for this kind of situation, I prefer to use very small size, but fractional pico laser. Exactly the same. Pico or nano. Or nano. Fractional. Pico or nano. If I use Q-switch classic, I defocus. Okay, and induce a purpuric reaction. And it works very well. Exactly. Yes, the both. And even for xanthelasma.
No way.
Yes.
Wait. So you switch.
Yes.
Defocus, so go on.
5 centimeter no more. 1064. But with the pico is the same. On defocus, and you multiplicate, you induce purpuric reaction. It works very well. On xanthelasma, on 10 years, more than 10 years ago, 15 years ago, they published, the first paper was published for Q-switch laser for xanthelasma. And the xanthelasma is not so far away from sebaceous, you know? Okay. Same. On the risk for dark skin to use 1064, you multiplicate, you induce. Patients go out with punctiform and purpuric reaction. It is normal, like for xanthelasma. It works very well.
I'm going to try it.
Okay, I also showed my secret sauce. in syringoma, I agree with Dr. Lee, Sang-Jun Lee's CO2 drilling technique. You can find it many pinhole technique is papers, right? So I usually use a 0.5 millimeter spot size with a ordinary CO2, not fractional, because it's fractional is not easy to correct place that syringoma areas. So it's non-specific, right? It's CO2 drilling is more specific. So second is in a sebaceous hyperplasia and a xanthelasma. I think it is very good to the 1760s. 26 sebaceous gland.
You just took Muriel, she was just whispering this to me.
Oh, no.
You heard us.
No. Specific laser will be the best. Wow. But it's really expensive. So how can we buy it all lasers? So I like 14, 15 nanometer. 14, 15 nanometer is not specific, but relatively specific to the sebaceous gland. It worked well. In my clinic, I'm using the 14, 15 nanometer laser. It's a cheap, really cheap. It's kind of a diode laser. Yes, cheap. So try it. Yeah.
Great advice. You should add to it, Muriel. It was your idea after all. No.
Yes, it was to open the doors in the future. So I have some French colleagues who have the new laser, acne lasers at 1726 nanometers, and they're working on sebaceous hyperplasia, and we say that they have good results. So perhaps in the future, but of course it's very expensive.
For Korea Derma in December, I propose a lecture on how to treat xanthelasma. Okay, because how you treat xanthelasma? Surgery, okay, when it's possible.
Let's make a genderless work in Korea derma.
What?
A lot of techniques together.
Yes, we have a lot of
Fractional
techniques.
CO2 laser.
How you treat it? How you treat?
If I can remove it, I prefer to remove it. If not, I'm going to start treating it your way, which is the defocalized Q switch.
Q switch, my favorite is CO2, fractional CO2, and some drop of phenol.
Really? And
Yes.
what concentration of phenol?
Finzi. Finzi formulation.
Without proton.
You have Finzi's formulation from Israel. You have Corchon.
That's Marina Landau's.
The formulation is Finzi's formulation. He's died,
Okay.
but
Great.
the mentor of Marinando was
Mentor.
because Finzi was a dermatologist and histopathologist.
So it's a laser-assisted drug.
And you apply very gently just after CO2. But you can use Q-switch. He was published more than Thierry Fusat, the French guy. And the US guy tried to do the same, but they don't understand why it doesn't work in the second publication. Because the most important, if you want to use, I give you a trick, a tip and trick, because it doesn't work enough. You use 1064. 1064, the target on 1064 is not the cholesterol. The target is water.
Yes.
You have what? You have to inject some lidocaine saline just below and inside to increase, to elevate and to increase water inside cholesterol. And you have the target. If not, it doesn't work.
Why don't we do that with melasma as well? Or pigmentation? Inject tumescent or saline before doing the Q switch.
It's a tip and trick, and I prefer to keep for me. Only.
Let's publish it.
So, like to treat xanthelasma or papillary acne scars, what I do is, if a patient is having tendency to heal with hyperpigmentation, I used to do Elman RF before, but it used to require multiple sessions. So what I do now is I do CO2 for the patient who is going to heal with hyperpigmentation, and after CO2, I use laser-assisted drug delivery. I have of triamcinolone 10 mg. I just lay it over. If patient is having tendency of hypopigmentation, then what I do is I basically do erbium YAG 2940, and then I lay some fractional. I'm talking about fractional only, and then I lay over the 5-fluorouracil of 1 or 2 drops. So hypopigmentation in healing process, that is taken care with that. Yes. And for xanthelasma, I do the same thing. I use 1064 to remove the superficial layer, and then I give 1 or 2 passes of CO2, and it's done. And in context to the acne scars and acne, when I come across acne patient, I make sure if he's having tendency to scar, from the day when I start microneedling radiofrequency along with isotretinoin, and along with isotretinoin, along with microneedling radiofrequency, there is a dermaceutical called as Uber Pro peel. I lay over that peel once I do the microneedling, and it makes, so because of that, what happens is acne lesions heals very faster. Also, new acne scar doesn't come, and the existing scars, they start improving.
What is it called? What's
Called
the
as Uber Pro peel.
Uber propene?
Yeah, peel it is.
Uber?
Yeah.
Like
Uber.
the car company?
Car company, yes. And the second in second session, what I do is I do MLA toning. Again, it creates leobe there. Once the leobe is created and pinpoint bleeding is created, I lay over the Uber Propyl with the mask, keep it for 20 minutes, along with isotretinoin, get amazing results. And once the acne treatment is done, if the skin barrier is intact and patient's skin condition is good, then I start with ablative lasers and like subcision, along with punch excision and suturing if needed in
the
atrophic and
surgical
boxcar scars.
Very good.
And if the scars are like very superficial or what I would say is open pores sort of, then I do TCA cross and along with some PDO threads.
Awesome. Thank you so much for sharing. Look, guys, our final speaker didn't show, so it's really up to you. We can have an early afternoon if you like to have a coffee, or if you really have like a pressing question, I'm going to give you 5 seconds to decide. If my co-chairs are happy with it, we're done. Hugh, the big boss, are you happy with it? Do I have your okay?
Yes, I see about laser. I see some from hair loss. You really, I see in many papers to stimulate hair growth by laser. Not photobiomodulation, laser like NDAB, non-fractional, fractional. Does it work really or not? Do you have any
There's a company called, well, without mentioning companies, there's a couple of companies that are aggressively promoting some of their lasers for hair growth. One in particular using NDAG wavelength. My friend happens to be one of their speakers, and he swears by it. He says that it works really well. I use fractional radio frequency in combination with exosomes and other injectables to stimulate hair very successfully. I think there's something there. I think if you can, something to do with improving vascularity, and you can look at some of their studies. I'm not sure the ablative wavelengths make sense, but the non-ablative, yeah, I think there's something there. Neoangiogenesis, yeah.
But you can, you think
I do really superficial laser, the fractional laser, and then no, I don't have a Korean one. No, the coring. Oh, the coring one. Yes, I use 0.5 millimeters in a 2% distribution. It's kind of painful, so I use a really, it's not really tumescent, but super dilute Lido with epinephrine so that it doesn't bleed. And then I put topical exosomes on it because, as you know, we cannot inject. So we're skirting the edge there. But great, yeah, well, you can get away with it. I cannot. But great hair.
Are we allowed to mention brands here? I mean, is it okay to mention brands?
Yes.
Okay. My question is a quick question for anyone. If you were to choose just one skin tightening energy-based device for your patient, just one or two, maybe two, what would be your favorite? I'd like to know.
This is very personal answer, and it varies from doctor to doctor depending on your patient population, their goals. I'm going to skip it. But we can speak privately. I can share my opinion. Patrick can speak to you and share his opinion. But let's keep it non-commercial. I think it's better.
Yes.
We have our final speaker here. Welcome. Oh. We have been waiting for you. Round of applause. Please come on up. Okay, so you've made the decision for us. We're going to continue the day.
No, she's okay. No need. You want?
No. Sorry, I'm trying to. Yeah, my mistake. I think she's tall enough. Okay, let me set you up.
So, if I have a fire in my clinic, I take only my CO2 with me. And I have more than 15 devices in my device on really CO2. Yeah, more than 15, yes, now. But only my CO2 laser.
I'll take my fractional radio frequency microneedling, but without marketing names. Okay, please, Dr. Warisa, it's all yours.
May I have the stage?
You want to have it? Okay.
Okay,
Thank you. Should be proper. Stand tall.
Thank you. Good afternoon. Thank you. Good afternoon, everybody. Sorry for being a bit late. So my name is Dr. Warisa Tayankanon, and I'm here to talk about how PRP can rescue the PIH problem, which is very refractory. I'm also known as Dr. Fafar here. I'm very happy to return because I used to talk in IMCAS, Paris, last January. Let me begin. So PIH remains a challenging skin condition, especially in Asian skin. Prevention is always better than treatment. However, once PIH occurs, what are our options? Where does PRP fit into the treatment plan? And today, we will review the underlying mechanism and discuss a practical case from my clinic, including how I approach and manage it. I have no sponsorship for this talk. Sorry, but may I have the clock for me?
You want a clock, like a countdown?
Yeah, countdown. Or you can tell me when
I'll tell you when you have
Thank you.
5 minutes left, okay?
Okay, because I prepared 12 minutes at first.
Go ahead, don't worry, we have
Thank
we
you.
have time.
So please let me briefly introduce my background. After MD graduation, I specialize in preventive medicine and dermatology and has joined a lot of medical industry, which gave me opportunity to learn and actively share advanced knowledge in aesthetic medicines. First, what exactly is PIH? The PIH, or post-inflammatory hyperpigmentation, is the darkening of the skin that develops after inflammation or skin injury. It's especially common in skin of color, including Asian patients, and can be frustrating to treat because some may take several times, like months to years. And so the prevention is more than important, and you can notice that the epidermal PIH is brown, but the bluish gray presentation will be the dermal PIH. Let's take a closer look at the pathogenesis. Inflammation triggers the release of various inflammatory cytokines, which stimulate melanocytes to produce excess melanin. Some of this melanin is transferred to surrounding keratinocytes, resulting in epidermal pigmentation. However, some pigment is engulfed by macrophage and becomes trapped deeper with the dermis as melanophage. This is one of the main reasons why PIH can be so persistent and last for years. The literature describes a wide range of skin conditions that can lead to PIH from the previous two slides. You notice 3 common themes: skin of color, hyperpigmentation, and inflammation. Regardless of the trigger, inflammation plays a central role, and it is also a part of wound healing process. To better understand why PRP may play a role, let's first take a closer look at the normal wound healing process. So we can divide in 4 overlapping phases. Start with hemostasis, inflammation, proliferation, and remodeling. The first phase is hemostasis, which occurs immediately after the injury, and platelet aggregates from the clot. Still followed by the inflammatory phase, which usually lasts for several days, and neutrophils are alive, which release cytokines and growth factor to promote tissue repair. And the next step is proliferation. Typically occur 3 days, day 3 to week 3. During this stage, fibroblasts produce collagen, new blood vessels are formed through angiogenesis, and keratinocytes migrate to restore the epidermal barrier. And finally, the remodeling phase continues several months. Excess inflammation occurs during the early phase of wound healing, and the entire healing process can become dysregulated. This raises an important question: if we can modulate inflammation early in the healing process, could we reduce the risk of severity of the PIH? So why PRP? Because PRP is a natural cocktail of growth factor and cytokines involved in wound healing, and it contains many of the key mediators that help regulate inflammation and support tissue and repair across different phases of healing. Such a promising option, isn't it? Naturally, researchers wanted to test this hypothesis. This finding has been supported by multiple randomized control trials, which consistently show faster wound healing in PRP groups. And also in this study, similar to the other study, PRP-treated group demonstrated faster wound healing and lower level of inflammatory cytokine compared to the control group. So we've seen that PRP can help moderate inflammation and promote wound healing. How about pigmentation? The study suggests that PRP helps reduce pigmentation by protecting melanocytes from reacting oxygen species, thus decreasing melanogenesis. Putting all this together, PRP appeared to target 2 key drivers of PIH: inflammation and pigmentation. In this laser-induced PIH study, the PRP group developed significantly less PIH, likely through inflammation modulation and faster restoration of the epidermal basement membranes. So how often should we perform PRP injection? Based on expert consensus evidence, PRP is recommended every 1 to 2 weeks with around 3 to 4 sessions per treatment course. After that, we can evaluate the response and consider other treatment options if needed. So how should we prepare PRP? According to this paper, around 30 ml of blood is collected, which usually provides approximately 5 ml of PRP treatment. The recommendation correction is to have some anticoagulant inside. But however, there is no standards for the protocol. Can PRP improve hypopigmentation? This paper presented a case report of post-laser hypopigmentation treated with PRP after topical steroid treatment showed no improvement. After 3 PRP sessions, the patient pigmentation improved and returned closer to the normal skin tone, as shown in the picture. Most guidelines of PIH mainly focus on the pigmentation. Next, I would like to share my personal treatment protocol for PRP preparation. I collect 20 ml to get PRP 4 ml, and I use sodium citrate tubes in preparation. Let's look into the case. This case is 27-year-old male patient with no previous treatment history. He undergo picolésion laser. This is 5 days after his treatment. You will notice pigmentation in his skin more than normal. For this case, I treated him with PRP at first, the full face, especially aiming on the wound, and also the scar gel. I also prescribed the topical steroid at first. And this is 2 weeks after, as recommended in the protocol. You can notice some hyperpigmentation on the wound that he has. So this time also, according to the research, I inject him with PRP again. And topical skinolin, I also prescribe oral transamine. Also control the inflammation with IV vitamin drips. This is 4 weeks after the hyperpigment event. You will notice like very normal skin right now, but still some hyperpigmentation. So the patient asked me to control his pigment. I offered 675 nanometers because of the collagen stimulation and very low fluent one. Also, I applied the PRP again. But you may notice that the hyperpigmentation seems a bit prominent this time. Maybe because the skin around seems brighter compared to the hyperpigmented area. This time, I also discussed with him that I will focus only on the hyperpigmented area, but not on the other skin. And this is the result when I focus only the pigmented area. So this time, I tell him I will switch to the picosecond laser but toning mode, and also prescribe the anti-inflammation vitamin. And this is the result. This is around 5 months after the event. You can notice that PIH seems near totally gone. I prescribe peeling at last, together with the anti-inflammation IV drip. And you will notice this is the last visit of his. He is quite satisfied with the result. This time I also do the picosecond laser toning on the area, also control inflammation on the IV drip. This is before treatment, after the treatment, and 6 months later of this protocol. This case is the burn from RF machine. I inject PRP right after the burn event, and you will notice 6 months later there is no hyperpigmented area, very minimal to less, visibly seen. This is hypopigmented area because of the picosecond in the superficial layer of the dermis. You can see that it turns into hyperpigment later. But this case, unfortunately, she's lost follow-up, so I cannot tell further what will happen after this. It was truly an inspiring moment for me. I had a chance to meet so many people, talented people and experts from around the world. just like here today from IMCAS Paris. If you have a chance to visit Thailand, do not hesitate to visit my clinic. We can offer free massage upon Google check-in. If you just drop by and say hi, we are more than welcome you.
That's very nice.
Thank you. This is my reference. You can go on and search for more detail about what I talked today. Thank you.
Thank you very much. Please have a seat here, Dr. Warissa. And if there's anybody who'd like to ask any questions from the audience about post-inflammatory hyperpigmentation, the use of PRP. Any questions from my co-chairs? Could be, yeah. Please come on up to the microphone and.
You mentioned transamin. That's tranexamic acid, right?
It's oral transamin.
Right, tranexamic acid oral. Did you mean 500 milligrams once a day or 250 twice a day?
250 twice a day.
Okay, my question, doctor, is it's getting very popular also in the Philippines that they're giving tranexamic acid oral, and personally, I see that it works. My question is, do you have any lab tests, because it's still poorly explained, the blood clotting mechanism and all that stuff. So do you, in your practice, do you require a certain lab test prior to giving the tranexamic acid? That's the first question. The second is, who would you disqualify? Personally, I disqualify people who are women who take oral contraceptives. I disqualify patients who've had previous stroke, and what else? Heavy smokers. Yeah. So the third would be, what is your protocol in general? How long do you give it? How do you taper? So on and so forth. Thank you so much.
Okay. For this case, this is a guy, first of all, so she's not like a female patient and not in a old age. I don't have any blood test before I prescribe the oral transamin, to be honest, because in my setting of clinic, the patient just like take the medicine and go. But I prescribe in this case because of the PIH and prescribe like only 1 month to reduce the PIH, because in the other case, I don't prescribe and PIH is more visible.
I'll add to that. I love it for PIH as well. It's my go-to just to get patients to recover faster. I'm no longer using it for melasma because it's not a permanent result. You take 250 in the morning, 250 at night for 6 months. I also, contraindications for me are oral contraceptives, heavy smokers. Otherwise, actually, it's quite safe. This idea of history of early stroke, I spoke to a hematology colleague. He told me the doses we're using are quite low. But nevertheless, we want to be safe. Melasma, the problem is it's a miracle. They come back 6 months later and the melasma is gone. And I get gifts and, dates and olive oil and incredible happiness from the patient. But then I warn them, because you've now stopped the drug, melasma is going to come back. You need to have another modality to try to control it. When it comes back, it can sometimes come back with a vengeance. It can even come back worse than before. I don't know if people have had that experience as well. So I've stopped using it for that purpose.
Delivery assisted.
I haven't tried it. I know some colleagues who have, who report mixed results. Some people have said they're happy, some people have said they're not. And topically as well, I know, Diane, you used it on your case, but I've also heard mixed results on topical. What's your experience?
I have some colleagues in Tunisia. They have a lot of
experience with
experience
it. They're happy with
and
it.
they have good results with drug delivery with tranexamic acid.
And when they stop doing the sessions with drug delivery,
of course,
comes back.
Yes.
Which is the curse of melasma. Any other inputs, or come on up to the microphone, please. And Patrick, you can talk to us in the meantime.
Well, using tranexamic acid, once you get the best result, actually you can taper the dose, become once a day. and then going to decrease the 40% of rebound or recurrence right after you stop the medication. So they say, yeah, so they can try. That's what you can try.
Eventually, you have to stop it, right?
You know, one time I usually tell my patient, why do you want to treat melasma? You keep coming back again and again. I say, once it can get improved, I will pay all the money to get the very short-term improvement. So that word touched my heart. So that's why.
The money or the okay. Because the money touched my heart, but I'm just kidding. No, but the patient satisfaction, of course, at the end of the day, we all want to help our patients.
So,
You had a comment, please come on up. Yeah, we have a little bit more.
Thank you for the time. I am Dr. Ahan from Indonesia. I want to ask for the first question, did you use any topical medication for your PIH patient, like maybe hydroquinone or any bleaching agents? And then the second question, as we know that in Thailand and Indonesia, especially patients with Fitzpatrick 4 and 5, they have more risk to generate more complications on such PIH. When you are using the pico lasers 1064, how much fluence is the safest that the range that we can use? Thank you.
So the first question is, do I prescribe any topical medication to reduce the PAH? Well, in my practice, I don't have any medication in my clinic, but I will tell the patient to go and buy. Like I put in the slide, Skinneren, the brand.
Skinneren, is it hydroquinone?
No, it's not hydroquinone.
What is it?
Yeah, azelaic. So
Azelaic acid, 20%?
Yeah. I had bad experience with the patient compliance, especially Thai people. So I won't prescribe any medication that is hard to adjust because patient compliance is the key of the treatment. So in my experience, I don't prescribe hydroquinone, but I prescribe the azelaic acid. The second question is the picosecond fluent. The fluence, I normally go for the lowest possible. For the, you ask in PIH patient or you ask in generally treat? Picotoning, not in PIH indication, right? Okay. Lately, I don't recommend my patient to go for the picosecond because I prefer using the 675 because it's more safety. And Thai people like brighter skin with better collagen.
So you get some tightening there as well.
Yeah,
Okay.
so I chose that laser. Lately, I don't do the picosecond anymore. Thank you.
So, Fadi?
Any other comments? Or yes, please go ahead.
Okay, so do you experience any hypopigmentations, complications, and which modality do you guys use to help?
Hypopigmentation from what?
Hypopigmentations.
You mean in general, when you have hypopigmentation, what do you do?
Okay, from picosecond laser.
Okay. I'm just getting my Pico now. Anybody have more experience on Pico? No. You don't have one either. Do you have one?
In that case, I use fractional lasers for the hypopigmented region. As you know, vitiligo, at that case, we use UVB, narrowband UVB therapy. But after treatment, after laser hypopigmentation, at that case, we can use fractional laser. Yeah.
Oh, okay, so when you use fractional laser, do you put any topical medication after? Okay, thank you so much.
Any other comments or questions?
Talking about the oxidation, we know a lot of oxidative stress, and so do you have any experience of any oral supplement of antioxidant? Because I know there are a lot of oral supplement in Korea and Japan, so I don't know whether you as doctors have any experience about that.
Any antioxidants that people are applying for?
Oral ones.
Okay. Since I learned about anti-aging medicine and preventive one, so I will suggest you like the well-known one, the astaxanthin. I remember that I put in my slide, but it's gone. Fine. So astaxanthin, coenzyme Q10, ALA, pycnogenol, all of these substances have a lot of study in an anti-inflammatory in our body. The thing that you may notice after taking some supplement is the brighter skin and the better quality, or even melasma. I have several cases that just take the oral supplement, the melasma can be gone. Maybe due to the mechanism that it can anti the reactive oxygen species that can hurt the keratinocytes or melanocytes. Maybe.
Thank you.
Thank you.
All right, so I think we're going to have to wrap it up. Thank you very much, everybody, for your input. I think it was a very engaging and informative session.